Okay, we're going to get started. Hello and good morning, everyone, or good afternoon if you happen to be on the East Coast. So, welcome to the I-STARR webinar series. I-STARR stands for Infrastructure for Studying Treatment and Addiction Recovery Residences, and the I-STARR project aims to develop infrastructure to advance science on recovery housing, particularly recovery housing for persons treated with medications for opioid use disorder, or MOUD. So today we'll be hearing from Dr. Jennifer Miles, who will present findings from her pilot study examining MOUD utilization patterns during the first 90 days of their stay in recovery homes, as well as the relationship between MOUD use and organizational factors within recovery homes. Now, if you've been to one of our webinars before, you'll remember that the I-STARR project is supported by a grant from the National Institute on Drug Abuse. And it's also part of the larger NIH Helping to End Addiction Long-Term, or HEAL initiative. It's also one of several projects that comprise the Consortium on Addiction Recovery Science, or the COARS network. So just some quick housekeeping rules or notes, about the format of the webinar. So the audience members are currently muted, and we encourage all attendees to use the Zoom function chat to introduce themselves and connect with fellow audience members and to ask questions of our presenter. We do have an I-STARR project staff member monitoring the chat and will unmute audience members after we hear from our presenter, and so that attendees can raise their virtual hands and participate in discussion at that point. Also, this webinar and each webinar in this series is being recorded so that those who are unable to attend today will be able to learn from it in the future. So finally, a reminder that closed captioning of this webinar is available within Zoom, and you can find it using the functions at the bottom of the screen. Next slide, please. So I am Carmen Masson. I'm a faculty member at the University of California, San Francisco, Department of Psychiatry and Behavioral Sciences. The I-STARR project is led by Drs. Amy Miracle at the Public Health Institute and me. And the team also includes co-investigators, Dr. Sarah Zemore, Dr. Lenny Jason, Dr. Mina Subbaraman, and Dr. Libo Lee, and communications specialist Diane Schmidt, and our team project coordinator, Quinoja Capitani. Next slide, please. So we are so fortunate to be working with an amazing 17-member advisory board comprised of a diverse group of leaders from across the country. Our advisory board members represent recovery and recovery housing leaders, treatment providers and payers, national policy advocates, and also researchers and educators. Next slide, please. So let me move on and tell you a little bit about our presenter today, Dr. Jennifer Miles. Dr. Miles is an instructor at the Center for Health Services Research at the Institute for Health and in the Department of Family Medicine and Community Health at Rutgers Robert Wood Johnson Medical School. So using primary survey and qualitative data combined with population level administrative and healthcare claims data, her research aims to build reliable evidence on effective strategies to increase equitable uptake of evidence-based practices for people with substance use disorders. Her work has been funded by the National Center for Advancing Translational Sciences, the National Institute on Drug Abuse, and the Preparedness and Treatment Equity Coalition. Her research has been published in high-impact journals such as Health Affairs, Drug and Alcohol Dependence, and JAMA Network Open. Without further delay, let's turn the presentation over to Dr. Jennifer Miles. Thank you.
Great. Thank you so much, Carmen, for that introduction. And I'm delighted to be here today. As Carmen mentioned, I'm faculty at Rutgers based in New Jersey. So I am on an East Coast and sweating. It is hot today. So I hope everyone is keeping cool if you're over here on the East Coast. And I'm going to be describing the pilot study that I-STARR funded that is looking at medication for opioid use disorder utilization among Philadelphia recovery home residents. Next slide, please. And I have to start, of course, with acknowledging my funders, and many folks who have supported this work, whether that be our I-STARR team, including my study mentor, Dr. Carmen Masson, as well as partners at the Philadelphia Department of Behavioral Health and Intellectual Disability Services, or DBH IDS, including recovery home operators that are contributing to this work, as well as folks actually at the department, including the Director of Research, Dr. Suet Lim, and an analyst and epidemiologist, Dr. Melissa Wardle, who are helping with some of the data that I'll describe in a moment. And also want to acknowledge my funding from NIDA that is also supporting my effort. Next slide, please. So I want to give a broad overview of the motivation behind the study, and then I'll get into some more specifics about the pilot study itself. But what's really motivating this work is that we have this evidence-based practice for people with an opioid use disorder, which is medication treatment. This refers to methadone, buprenorphine or Suboxone, naltrexone or Vivitrol. We know that these medications are highly effective, so we know that they reduce the risk of fatal and non-fatal opioid overdose. We know that they reduce acute care utilizations, whether that be the emergency department, hospitalizations, but we also see really across the board very low utilization or low uptake of this evidence-based practice, and that's across really every setting. And so we really are, a lot of the focus now is in implementation science to understand what contributes to successful uptake and implementation of this evidence-based practice in various settings. One setting that has a lot of potential for supporting people with an opioid use disorder is recovery housing. And we know that recovery housing provides lots of different supports for people to achieve and maintain long-term recovery in the form of building their recovery capital, social support, financial support, employment, peer networks, all of these things that we know are vital for people to build a life in recovery. And so the idea here is, can we actually increase the uptake of this evidence-based practice being medication for opioid use disorder within a supportive housing environment, which is recovery housing? And so we really want to understand what factors could facilitate this. And we know it's a promising practice, but we also know there are many challenges to that. And so whether that be, safety issues of storing and, residents taking their medication as prescribed, but also thinking about the broader culture and community within the house. So it's not just about that one resident, it's how is it maybe impacting both the staff who themselves typically have their own lived experience, and also the fellow residents. And so this study is not geared toward developing new interventions. It's really trying to understand implementation of existing evidence-based practices within a novel setting being recovery housing. Next slide, please. Now, if you had the ability to attend the webinar last month, you would have learned a lot about an implementation science framework called CFIR, or the Consolidated Framework for Implementation Research, which is one really broadly used implementation framework for conducting research in the implementation science space. This study relies on another framework called the EPIS conceptual framework. And it's really focused on how do we increase uptake of specific evidence-based practices within specific settings. EPIS stands for the exploration, preparation, implementation, and sustainment. So there's 4 phases to this framework. And at each phase, we're interested in specific factors and characteristics that might relate to the uptake of evidence-based practices. Next slide, please. And then click again, if you don't mind. Thank you. So this study is focused primarily on the preparation and implementation phase. And part of the reason for that is that the city of Philadelphia, where the study is set, already decided that folks that are using funded recovery homes in the city should be able to access medication for opioid use disorder if they want to. So they've already passed the exploration phase. And so this study is trying to understand what's happening within the recovery homes themselves at both the staff and organizational level that might be facilitating uptake of MOUD. And then during the actual implementation of this, what are some of the factors related to MOUD specifically that might impact fit of this evidence-based practice within the recovery home setting? Next slide, please. And you can click again. So for this study, with the preparation phase, we're really focused on two specific facets of this inner context within the recovery home that might be related to resident level use of MOUD. And those are organizational characteristics and staffing processes and practices. And the specific things that we're measuring are at the staff level. What are attitudes toward medication for opioid use disorder, available resources, the readiness to make this available to residents who would like to use it, organizational policies and practices, and whether house staff themselves are seen as a resource for supporting MOUD utilization. Next slide, please. And you can click again. Thank you. And then in the implementation phase, again, we're really focused on the fit of this evidence-based practice, again, being medication for opioid use disorder within recovery housing setting. And fit is being measured at both the staff level and the resident level. So at the staff level, we're thinking about the acceptability of this intervention, the appropriateness, the feasibility. And then at the resident level, we want to know, are there actually people who, might be candidates for this evidence-based practice, whether that be a history of opioid use disorder or opioid overdose, or having prior utilization before starting their recovery housing stay. Okay, next slide, please. So the key research question then is, what is the relationship between these house and staff level intercontextual factors and residents' actual use of medication for opioid use disorder? Next slide, please. And this study has three different aims, relying on two different sources of data. So the first aim will describe those intercontextual factors at the staff level, relying on house or staff level data. The second aim, if you can click through. Thank you. The second aim is focused on the resident level fit and the actual utilization or implementation of MOUD. So we're relying on resident level data. And then the third aim combines those two data sources to look at the relationship between what's happening at the house level that might be related to resident level use of medications for opioid use disorder. Okay, great. So now I'm going to get into the study setting itself. And that is specifically in the city of Philadelphia, within a system of 25 funded recovery homes that are funded by the Department of Behavioral Health and Intellectual Disability Services, or DBH-IDS. And what funded means is the houses receive a per diem rate for people to actually stay in the house. So residents often either do not pay fees, or they pay fees once they're able to, once they're employed and have a steady stream of income. There's about 500 beds across the system, and the houses are sex segregated, and so you can see the breakdown by sex of how many houses, and then related to that, how many beds there are. Next slide, please. Oh, other way. Great. There should be a link popping in the chat or already in the chat where you can go to the city's website that describes kind of the history of this system and also the various, eligibility and services. I'm just going to quickly mention Folks that are using these or eligible for these have a history of substance use disorder. So not just opioid use disorder, any substance use disorder. They're 18 years or older, and importantly, they're also enrolled in some form of substance use treatment outside of the home, whether that be IOP, outpatient, or if it's relevant, some kind of medication treatment as well. Next slide, please. And here's just a list from that website of the various services that are provided on site, where you can go this bullet point in blue, you can actually click on and see another list of the, specific recovery support services that are offered as well. And then I'll mention too that these houses have at least one staff member. Houses that are part of a larger parent organization may have even more staff infrastructure than that because of the resources available to them. But they are required to have some kind of staff on site. Next slide, please. And just to level set for folks who might be thinking in terms of the National Alliance for Recovery Residences levels of support, I want to just say kind of what these are and what these are not. So as I mentioned, these houses have staff on site. They have some degree of structured activities on site. So they really fall, within either a level 2 or level 3. They do not, therefore, because they have staff, they do not meet the level 1 description, and they're not offering any clinical services directly on site. And so they're not what we would think of as level 4, which might be actual residential treatment, for example. Okay, next slide, please. Great. Okay. So I want to spend a little bit of time talking about the various data sources. So this study relies on it's a mixed method study in that we're relying on qualitative and quantitative data, but we're also relying on a combination of primary data that are collected prospectively as part of this specific study and secondary administrative data that are collected for other purposes and other contexts, but we're leveraging to answer some of the research questions in this study. And I want to spend a little bit of time, especially talking about the secondary data, because it's not very common in recovery housing research that we even have access to this type of data. And I want to just talk a little bit about what it is, what can be used, and then some of the pros and cons of using that data as opposed to developing your own survey and questionnaire and then collecting it during the study is being conducted, while the study is being conducted. All of the resident level data for this study is coming from some kind of secondary administrative data source, being that it is collected for other purposes, but that it has rich information that we can use to answer some of our research questions. So these two sources for this study include data from the DBH IDS Recovery Housing Initiative, which will describe recovery housing admissions. So they collect all kinds of information when people are newly admitted to the recovery home, demographic information, but also their, substance use history, employment, education, all of that kind of information that helps the recovery home get a handle on, what kind of supports might be needed, how the fit for the house, things like that. The second source of data are coming from the Philadelphia Medicaid behavioral health carve-out. So it's Medicaid claims from their behavioral health carve-out, community behavioral health, or CBH. This data is collected just in the course of typical healthcare utilization for anyone that is covered by Medicaid and using their Medicaid insurance to pay for whatever that health service might be. So we're using that data to describe factors related to residents' health status, so various diagnoses that might be relevant, as well as to look at specific MOUD utilization patterns based on either prescription data or healthcare procedure data related to, for example, if you're using an injectable formulation, there's going to be a procedure code for that actual injection having been done. Or in the case of methadone, it's being dispensed by some kind of healthcare provider. So we need to look at procedures as well as prescription data. So Kunaja, you can click the next button. And so here's just a quick recap of what I was just describing. From the Recovery Housing Initiative data for now, we are relying on demographic information, as well as the length of stay in the recovery home. So how long between the day they were discharged and admitted were they living in the home? Okay, next slide, please. So I want to talk a little bit as well about who of the residents are eligible to be included in the study, because that has important implications for maybe limitations and benefits of the data. So the first is we're looking at admissions between January and June of 2025. And in secondary administrative data land, that's actually very recent data. For example, Rutgers has national Medicaid data that is as recent as 2021, which we can assume there's been many changes and important trends that have happened in that data since then, and are certainly coming up in the next year or two. But unfortunately, we don't have the ability to look at that data quite yet. And so, um, but I will say, really, any administrative data is probably going to have some kind of lag in when it's available. So, for example, even for the data in this study, we have, an admission date, and then we're following people for 90 days. So that's already a 90-day kind of delay that's baked into the study design. Then we have a 90-day lag to allow time for those final healthcare claims adjudications to happen. So as you probably are well aware, whether it's personal or professionally, there's all kinds of back and forth that can happen between providers and insurance to kind of finalize those claims. So then we have another 90 days waiting for that data. And then it takes time for the data provider, in this case, DBH IDS, to actually extract that data for us. So while there are many pros to using the secondary data, being we can collect information on a lot of people back many years, kind of all at once. We do have, some waiting period. And in addition to that, there's all kinds of data security that needs to be in place to carefully protect that information. And so you go through an entire legal process where you're putting in place all of these protections to ensure that the data are properly secured. Um, all right, so that is the admissions are for January to June of last year. This is specifically people who are enrolled in Medicaid continuously during the entire study period. So for us, that is basically a 6-month period before their admission and then a 90-day period after they're admitted. We want them to be continuously enrolled during that time because we want to make sure that if we're not seeing an outcome that we're looking at, we want to be sure it's because they're not using, for in this case, medication treatment, as opposed to it's just missing because they didn't have insurance or they were covered some other way and we're missing that information. And similarly, we are excluding people who are dually eligible for Medicare because when you're dually enrolled, Medicare is the primary payer for prescription medications. And so we would be missing outcome data because it's just not in the Medicaid claims, it's in the Medicare claims. And then we're also limiting this to people with a record in their Medicaid claims of having an opioid use disorder diagnosis or a diagnosis of a non-fatal opioid overdose. But we know there's plenty of times where people are experiencing an overdose in the community and do not actually then have a subsequent engagement with the healthcare system. So if you're not then showing up at emergency department, for example, we would not know about that overdose. And also, we know that there's a whole lot of underdiagnosing as well. So we are limited to folks who have a documented diagnosis of either OUD or overdose in your Medicaid claims. Next slide, please. I'm going to quickly go through the recovery home house level data because the results I'm going to be describing are really focused on the residents, and I want to make sure we have time for discussion at the end. So as I said, the resident data are all that secondary administrative data that are collected for other reasons that we are just leveraging for our study. The recovery home manager data, that's gathering information on those intercontextual factors about what's happening in the house. Our primary data, meaning we developed a survey that is sort of a compilation of various, existing and validated questionnaires that we are then collecting prospectively as part specifically for this study. So that there's a survey, and then we're kind of going a little bit more in depth with some individual interviews with house managers as well. You can click the next. Great. The survey takes about 30 minutes. You can do it electronically or on paper. The interviews are scheduled to be about an hour. You can do them in person or over Zoom. And I can talk a little bit at the end about some challenges that we've been experiencing with actually collecting some of this data. But for today, I'll be really focused on the resident level preliminary results. And also, if you're wondering more about the survey itself, I'm happy to say more about what's actually in the survey. Next slide, please. And for the staff level data, we're really enrolling or recruiting rather one person per house that kind of oversees the daily activities. They know what's going on. They're there on a, if not daily, then most of the time basis. Someone who is the program manager for many houses may not know all of the ins and outs of that particular house. And so they might not be eligible. We really want the person who knows that house inside and out. And for the survey, we're hoping to collect one for all 25 of the houses. And for interviews, we're hoping to target about 10 or 15 people. Okay, next slide, please. And then to answer that third study aim where we're combining both the staff level and the secondary data on residents, we have to physically link those data. And so we have a random ID for both the house and then the residents that are in both data sets that we can then use to link them together to answer some of those questions that really rely on both sources of data. Next slide, please. All right, so I'm going to shift gears and talk specifically about that second aim. So again, this is the one that's focused on the resident level data where we're looking at their medication for opioid use disorder utilization patterns, and I'll describe the study measures and defining them a little bit. So next slide, please. Okay. So first, we want to just simply describe who's in the sample. So we have various demographic characteristics that are collected by the DBHIDS, the Recovery Housing Initiative, at admission. And then we are also including a length of stay because we know from lots of research on recovery housing that the longer you stay, the better your outcomes are. So we're also including a measure of how long people are staying, and that's measured in days. Next slide, please. The next set of measures are all focused on MOUD utilization patterns. The measures in this table are observed at both baseline and follow-up. So we want to know, was there any utilization at all? Yes or no? Yes, if there's at least one or more prescription or one or more procedure related to some form of MOUD. We want to know, on average, how many days people had access to that medication. And so, for example, prescriptions can be written for various lengths of time, various dosages as well. We're not really getting into dosing in this study. But to measure supply or access, one prescription that's written for 14 days gives you 14 days of supply. One that's written for 28 days is 28 days supply. If someone has more than one prescription written during the time frame, then we're adding up those days supply to then get us the next measure, which is the average percent of days covered. So this is a measure that's used a lot in various, pharmacoepidemiological research. And really the target that they use is having 80% or higher of the percent of days covered with supply that indicates that someone is engaged and continuing in treatment. Next slide, please. Okay, so those are both measured at baseline and follow-up. These two measures are just observed at baseline. So we're interested in the average number of days between the most recent available medication supply is and when someone's admitted to the recovery home. Because, we want to see, are people coming in and they're already using medication treatment, and do they want to continue during their stay? Have they not used anything and maybe want to? Or is there some kind of gap between and maybe wanting to get reconnected with care? The next measure is the number of admissions with supply that's left over at admission, meaning there was a prescription written so recently that they still have medication available to them at the point that they're admitted to the recovery home. Because these, again, might be candidates for continuing using that medication during the recovery home stay. Okay, next slide, please. These measures are collected specifically or observed specifically at follow-up. So kind of carrying along with the supply left over measure at baseline, do folks that have supply left over have any utilization during this 90-day follow-up period? So, thinking about people with continuous utilization during the study period. We also want to look at people who might be considered new starts, meaning they had no utilization in the baseline period, but they started having any utilization during that 90-day follow-up period. So if you remember, these recovery homes, require that people be engaged in some form of substance use treatment during their stay. So in theory, if someone is interested in starting medication for opioid use disorder, this would be a great way of getting someone connected to care because they have this supportive housing environment, and now they're also being required to engage in some kind of external treatment as well. So giving people more opportunity to connect with a prescriber, for example. And then we're also looking at the average, oh, I think there was one more. The average time to the first dispensed medication after the recovery home admission. We know in various general medical, but especially in behavioral health contexts, there can be really long wait periods to get started with treatment. So we want to know, how long are people waiting once they start a recovery home stay before they have access to their medication. Next slide, please. And I just want to quickly go through a couple examples of what these utilization patterns might look like in the data. So this first person has no supply throughout, so they have no utilization. So they'd be a no on both the baseline and follow-up any utilization measure. The second person we're describing as discontinuation during the baseline period. So they have a few months of medication supply and then no supply after that. The third person is someone that has that leftover supply. So they had a prescription written very close to their recovery home admission that gave them some days of coverage once they started, but then they don't have any utilization following that during that 90-day period. So that would be someone we'd describe as having early discontinuation. The fourth person has sporadic supply, meaning they also have 3 months of coverage in the baseline period, like this second person, But it's more sporadic because it's not continuous. They have some supply, then they don't. They have some supply in the follow-up and sometimes not. So this person, and why it's important to understand these different patterns is because there's going to be different interventions and points of intervening for folks depending on what that utilization looks like. For example, person two, maybe they lost access to their prescriber, so they actually need a new prescriber. But maybe the fourth person still has contact with that prescriber, but maybe they're having trouble covering the cost of the copay of their medication. So they need a different kind of support and intervention than that other person does. Person five has continuous utilization during the entire baseline and follow-up. And person six represents one of those new starts. So they didn't have utilization during the baseline, but they do have it during the follow-up period when they're, during their recovery home stay. All right, so next slide, please. All right, so I'm going to get into some descriptive results of these MOUD utilization patterns. So next slide, please. And so this table just simply describes the admissions. I will say we're using the language of admissions and not unique people using recovery homes. There's a little bit of repetition in the data of who are having maybe multiple admissions during that 6-month admission window of the study period. Um, I was told it's really about 19 people, so it's pretty minimal. So mostly this represents unique people, but we are talking about at the recovery home admission level, not the unique person uh, unit, that is. So there's about 400 admissions during that 6-month period. Average age is about 45. Fairly even breakdown by sex, and then you can see the breakdown by race or ethnicity. And that follow-up period is 90 days, and we're seeing about an average of 83 days length of stay in the recovery home. And so that follow-up period is on average covering almost that entire 90 days. So we could reasonably connect, what's happening with the MOUD utilization during that 90-day period with potentially what's happening in the recovery home. So next slide, please. So this slide gives you a breakdown of how many people either, yes, were utilizing MOUD during both the baseline and follow-up, or who were not. And as a reminder, this sample is limited to people with an opioid use disorder diagnosis or an opioid overdose diagnosis. So, really potentially people who could benefit from and might be interested in using MOUD. During the baseline, we're seeing about 30%, so about a third of people actually having some utilization, and that's any utilization, so one prescription or, 6 or more. That's slightly lower in the follow-up period, but the vast majority of people have no MOUD utilization. Next slide, please. The next result slide is going to focus on people who had any utilization during that baseline period, so about that 30%. Next slide, please. So these are describing, the first measure is the average days supply during the 180-day or 6-month period before their recovery home admission. And so again, if we're calculating the percent days covered, that is the number of days of supply divided by the number of days during the period. So for this, it's divided by 180 days. On average, we're seeing less than half of the percent of days covered with any supply for people with any utilization. So not really hitting that 80% or higher mark that we look for. And then the second measure here is that days between the most recent supply and when people were admitted to the recovery home. So thinking about gaps or potential utilization when people are coming into the recovery home. And there's about a 3-week gap on average between, before coming in and starting the recovery home and when you had your most recent medication available. Next slide, please. All right, so then thinking about that follow-up period, following people for 90 days after their recovery home admission, people with any utilization during that period, which it was really only about a quarter of people, so slightly fewer than during the baseline period. Next slide, please. So now we're looking forward from the recovery home admission. And so the first measure, again, is that average days supplied during the follow-up period. We're seeing about 55 days on average, which is slightly higher. So about 60%, but again, not hitting that 80% mark that we look for. What is encouraging is for the average time to the first dispensed medication after the recovery home admission it's only 17 days, so about 2 weeks. And if you think in terms of wait times, for other services, that's actually seemingly pretty quick for people to, be establishing themselves in the recovery home and then also establishing follow-up care for medication treatment. Next slide, please. All right, so this is looking at people with any utilization sorry, for people with supply left over when they were admitted, which is about 67 of these 400, um, or about half, I guess, of the people with any utilization in the baseline period. How many had that any utilization in the follow-up period? And we're seeing that the vast majority, and I'm sorry, the legend is not matching up with what's so the darker blue is the people that, yes, they had any utilization in the follow-up period coming in having still medication available to them. So that's great. That's about 85% of those folks. We do see it is 10 admissions, so this is a small sample, but about 15% of people that had supply left over that did not have utilization during the follow-up period. So that, kind of raises the question of, why. We want to understand why they didn't have utilization during the follow-up period. Next slide, please. And then among those with utilization during the follow-up period, how many of them were actually these new starts? So people that did not have utilization in the baseline, but then started using MOUD during their recovery home stay. And we see that's about 25% of folks who are these new starts. So that's encouraging, right? If people are coming in, they might be a good fit for MOUD, and we're seeing them getting connected to care during their recovery home stay. Next slide, please. So just kind of some discussions and to summarize, so we are seeing kind of similar to the broader national trends of MOUD utilization. We are seeing kind of lower utilization rates. So about a third of people, or even about a quarter of people during that follow-up period who could be eligible and a good fit for MOUD who are actually using medication treatment. There's a little bit of evidence that we're seeing some discontinuation upon admission. So we want to try to understand that a little bit better. But we're also seeing evidence of newly initiated treatment as well. And then we're also seeing an encouraging kind of shorter time to that first fill after people start the recovery home admission. Next slide, please. So some limitations, not comprehensive list, but some of the key ones are the short study timeframes. So we're only looking at 6 months worth of admissions, about a half a year. But again, as I mentioned, we have this secondary administrative data where we can actually look back in the past really as long as we want. We just want to be aware of and accounting for any kind of policy and other things that might have changed over time that we want to account for when we're doing our analyses. This is a smaller system of city-funded recovery homes. It is innovative. It has been around for many, many years. It's one of the few examples in the country of, actually providing financial support to support these services. But we want to be thinking carefully about the generalizability because of their unique status. Within Philadelphia, there's probably over 200 recovery homes. This is 25 of them. And so we want to be considering that as well. And then we want to be thinking about the generalizability of who's in this study sample. It's people who are continuously enrolled in Medicaid. They have a documented diagnosis in their medical record. Um, versus many people who are not enrolled in Medicaid who probably could or should be, who have kind of, in and out of coverage for various reasons. So we might be missing a lot more people that, should be included in this study sample. Next slide, please. And so our next steps would be, so right now we just have the prescription data and the Recovery Housing Initiative data. We are also anticipating medical claims data. So we're going to be incorporating that. We're going to be summarizing data at the house level in addition to looking at the resident level data. We're going to be attempting to link the staff survey data once we get more of it with the administrative data. And sort of on that note, we are still collecting primary data. We may want to reconsider our strategy for doing that. We're also pivoting toward, rather than the house manager individual interviews, conducting focus groups with residents to understand better their experience as well. So happy to talk a little bit more about that during our Q&A period. And next slide, please. And that's all I have. So thank you so much, and I'll turn it back over to the I-STARR team.
Thank you so much, Dr. Miles. That was an amazing presentation. So at this point, we want to open things up for questions. For anyone in our audience who's interested in asking a question, you can raise your virtual hand or drop a question in the chat. So please feel free to reach out. There is a question there. Amy, do you want to field it? Or so it says from Paul Stevens. Do you want to ask your question, Paul?
Sure. Yeah, I was just wondering, excuse me, what the length of stay data was that you collected for this sample.
Sure, that came from that one of those administrative data sources. So from the Recovery Housing Initiative within the city's Department of Behavioral Health and Intellectual Disability Services, where they just collect, routinely information on when people are starting and then when they're leaving the recovery home.
But do you have like an average length of stay
Oh
or
yeah, I'm sorry. That was on one of the tables, but it was
I'm sorry,
80.
I missed
No,
it.
no worries. It was buried in that table. It's 83 days. And so if we're looking at a 90-day follow-up period, we can be reasonably confident that what's happening during that period can, partially at least be attributed to the recovery housing stay.
So rough, like was it about half that made it to 90 days or just under half or something like that with an average of 83 days?
That I don't know off the
Okay,
top of my head. I apologize.
that's fine.
But probably at least that, right? So, pretty solid group of residents making it that long.
Gotcha. Thanks.
Sure. Thanks.
I see another hand raised. Polly?
Hi, thank you so much for your presentation. That was really interesting, especially some of your findings about lower utilization, even though initiation was fairly quick. I'm curious, I know that you're working on the qualitative piece of the data collection, and I'm curious as to whether or not you have some sense about perceived incompatibility between MOUD use while in recovery housing, and to the extent to which you believe that the sort of persistent belief that MAT is not, quote unquote, being truly abstinent or real recovery, or some of those beliefs that still persist, and how those can sometimes run counter to what has traditionally been considered acceptable for residential treatment or for recovery housing is to be completely abstinent. So I'm curious as to whether you have some sense of that kind of popping up in all of this, even in the absence of the final qualitative analysis.
Yes. And so I can describe that absence as having two interviews. So I don't want
Okay.
to generalize from that. I think kind of how you laid it out is really how, what we're also curious about is understanding, we're seeing these low utilization patterns at the resident level. Is there some relation to what's happening at the house level, including house staff themselves and how they perceive MOUD and its feasibility and appropriateness and all of that? So we are asking questions specifically to get more in depth than just what our survey can collect, to learn a little bit more about how house staff really view it as well. Because, a lot of the literature, it's not even just recovery housing, it's all kinds of different settings that, folks are, still have those perceptions and views about it. So yes, thank you.
Great. I saw some, I see Roland, you have your hand up, but we also had some questions in the chat. So then we'll go to Roland and then some of the questions in the chat.
Thank you. I enjoyed the presentation, and I have a little bit of background with the DBH IDS, so and the whole recovery house system. But one of the things I was concerned about, maybe it was just me, did I miss the fact that you seem to be talking mostly about buprenorphine and
yes,
and okay, so there's still some work to be done as far as methadone is concerned. And,
yes, thank you.
And then the last thing I wanted to ask was, is there any correlation between continued, other drug use, for instance, whether it is alcohol, tobacco, and or other drug use that affects the study at all?
So briefly, I'll just say a little more of the first point is that thank you, because I realized later when I saw my discussion slides that I forgot to clarify that right now we only have the prescription data, so it really is only representing the buprenorphine utilization. I will mention that the naltrexone rates, at least in the prescription data, there were 5 admissions. And so I'm expecting to see more of that. And then obviously, so the methadone utilization in the medical claims data that's forthcoming. So thank you, because I did forget to clarify that. And then the other piece, I think that data could possibly come from the Recovery Housing Initiative data, if we're looking perhaps at their discharge data. So that would be something I'd want to go back to Dr. Lim. I don't know if you overlapped with Dr. Lim, Dr. Lamb, but I've been working with her. Yeah. So to figure out what is the universe of data that's available that could be incorporated in this study, and I would want to be adding in some of those more socioeconomic and other SUD history that might not be represented in the claims themselves. So thank you so much.
Thank you. There's also a question from Robin Thompson. Robin, do you want to ask your question?
Sure. Thank you, Dr. Miles, for your great presentation. First, too, I was really excited to hear about your use of secondary data in this, just with the challenges of working with recovery housing programs, with them being limited in resources and staffing, and it's always a challenge. So that was really interesting. I took a lot of notes, and I'm excited to hear more about the study as the results come out. But I was really just curious about, I guess, your plans for collecting programmatic data on the recovery homes. Just do you know yet about their length of stay, their recommended length of stay, if they have them? Because we know that recovery homes, some have recommended length of program stays for the residents, some don't. So that was kind of my first question.
I don't think these have a prescribed length of stay or a limit on how long people can stay. We saw an average of about 80 days. I was honestly expecting it to be a little longer than that, but again, this is 25 houses out of the many multitudes even within Philadelphia, so that could really be specific to this system. And we don't know why a length of stay is long or short. If someone is doing well and they're getting established in employment and they're getting reconnected with family and social support and they have housing, that's great, and they should be moving on and continuing in their recovery. So I don't really have a sense of kind of the interpretation of whatever the length of stay is, but I don't believe they have a prescribed length of stay for this system.
Right. I think we have time for one more question. Carlos Galicia.
Um,
He's saying in the treatment continuum is a recovery house program no different from a residential program in a clinical setting? Are all stages covered, including continuous care and post-treatment support such as social inclusion?
if I am not interpreting this correctly, please feel free to chime in the chat again because I see you're having some technical difficulties. But um, my understanding of your question to answer you is that no, they are not the same. And that's where we can go back to that NAR levels of support table to really kind of get a sense of how these fit in, at least within residential type of settings, outside of whatever other, intensive outpatient services, other types of community-based support for substance use disorder. So these are really they are residential settings. They do not deliver clinical treatment services on site. They are encouraging of people to link up with external services. Often it is someone who is being discharged from a higher level of care, like a residential treatment or a detox setting, and then they're coming to recovery housing. And then within the recovery housing continuum, there's also various intensities. So that run the gamut from more formal clinical residential treatment to the Oxford House model where it's peer run and there's not any staff on site, for example. I hope that answers your question.
Well, this has been a wonderful discussion, everybody. Really helpful. I hate to cut things off, but before we leave today, I want to give you some updates about some things that are coming up in the months ahead. Next slide, please. So next month's webinar will feature Dr. Niles Zoschke, and the title of his presentation is Tobacco Use in Recovery Housing, Determinants, Policies, and Opportunities for Cessation Implementation. In June, we're going to hear from our own Dr. Meena Subramanian, and she'll be presenting on cannabis use among sober living house residents. So unless otherwise advertised, the I-STARR webinars are held on the third Tuesday of the month from 11 to 12 for those on the West Coast, 2 to 3 p.m. for those on the East Coast. And you can register for any or all of the webinars that we've scheduled on the I-STARR website. And you can also stay connected with us through the social media accounts, which you have listed here on the slide. And while you're on the I-STARR website slide, you'll also see information about the I-STARR training series. And this training series consists of 12 webinars with separate training topics for recovery housing operators or providers, as well as those who are interested in conducting research on recovery housing residences. And those who participate in all 12 webinars will receive a certificate of completion, and you have the option also of being identified on our I-STARR website as someone who's completed this training. So at this point, the live webinars are over, and so we can track completion of the webinars if you register for the series and view the webinars on the I-STARR Learning Management System on the website. So if you have any questions about the training series, please feel free to reach out to us. So we are running out of time, and I just want to say again that we are so happy and pleased that we had Dr. Jennifer Miles today for such an amazing webinar. And I want to thank everyone for your time and attention. And we hope to see you again on Tuesday, June 16th. So enjoy the rest of your day and see you next month. Thank you.